but I said yes, and I was traveling to St. George's every day for 4 hours from Cambridge to London and back because my children. I'm spending a bit of time around Malta because I think where you live and where you grow up, it tends to influence very much what you do in later life. I think it's easy to be successful. It's easy if you have the right time, the right resources to reach the peak. If you have the right motivation, the right ambition, etc., etc. The issue is how do you sustain being excellent for the next 30 years? You know, no matter how important you are, being humble is the most important thing that people remember of you. I moved to London thinking, okay, I want to do a PhD on this topic, but I didn't. You know, what happens is that, you know, you have your own universe and your own landscape, your own team, you know, and you work on it. But what's also important, certainly for me, is the International Society of Addiction Medicine and the people that you meet as a result of setting up the Neuroscience interest group. So the question was, is chronic opioid dependence associated with neurological impairment? First, most important is be kind to yourself and others. Please, be kind to yourself.
Thank you very much for the invitation to host this fifth talk of this monthly series, In Love with Addiction Neuroscience, supported by the International Brain Research Organization and the International Society of Addiction Medicine. It is my pleasure to introduce Dr. Alex Baldacchino. He is a physician. He graduated in Malta in 1987 and later as a psychiatrist and specialist in addiction medicine in the United Kingdom. He is currently professor. He has he's a psychiatrist and a specialist in addiction medicine, and he now works as a professor of medicine, psychiatry, and addictions at the University of St. Andrews, also in the United Kingdom, and also as a senior consultant psychiatrist with NHS 5 Addiction Services in Scotland. He's currently the board director and president with the International Society of Addiction Medicine. Probably you met him in the first talk when he was presented the whole series on Hamed. He has been, as a researcher, he has been able to combine research, teaching, and clinical practice. And as a researcher, he has been the principal investigator of several European Union-funded projects and has numerous peer-reviewed publications, around about 150. And part of his interest had been the studying of co-occurrence of substance use disorders and mental disorders, and also to address the barriers and challenges to accessing treatment for drug users. And I also read something about the internet and addiction. And recently, he has also been interested in the problems associated with the current pandemic. As to clinical practice, I like this quotation from himself. In his own words, he said that he is honored to spend time with patients, trying to provide the best medical care with compassion and with quality. And I think this is very important for the field of addiction for everybody. Passion and compassion, the best clinical and scientific basic research evidence to make the life of people suffering with addiction better. It is my great pleasure and honor to introduce Dr. Alex Baldacchino to this fifth talk. And Alex, the floor is yours.
Thank you very much, Sylvia. I am truly honored and humbled with that introduction. I am speechless, which is not really a very good thing if I've been asked to speak for 45 minutes. But thank you very much, Sylvia. And as Sylvia had said, you know, in a way, sort of, I'm a man with many hats, and it is part and parcel of the professional journey that I've gone through, that I finished in the last 10, 15 years, to be doing so many exciting things and being able to do these things well, hopefully. And that's because I'm surrounded by really excellent and very able individuals and teams. So of course, you know, the running title is In Love with Neuroscience. I thought, you know, In my case, neuroscience was more a case of popular, and that's my presentation. And apologies for people who are perhaps hoping to hear me talk about the science, but it is more about the reflection of my journey, where I am now and what has gone through to reach this situation. And I'm very cognizant that this is, the main recipients of these presentations are people in their early career. So to explain to explain the logos at the top, as Sylvia said, I'm clinical director, consultant psychiatrist with NHS 5, which is part of NHS Scotland. That's my clinical universe. I'm a professor, full-time professor with the University of St Andrews, and I have a chair in psychiatry and addiction. I'm an honorary professor with the University of Dundee, which used to be my university before I moved on to St Andrews. I'm research and development director with NHS Research Scotland, and in the last year and a half, I'm NHS 5 director for innovation. Plus, of course, my association with International Society of Addiction Medicine as president of the ISM, which is a 10,000 strong membership of addiction specialists globally. A bit about where I was born, and that's Malta. And I never assume that people know where Malta is. I know in the audience that we have right now, I've seen Dr. Vella, who comes from Malta, but some people might perhaps, and it's okay if you've never heard of Malta, but hopefully, I hope most of you have. And Malta is a very, very small island right in the middle of the Mediterranean Sea. Actually, most maps, big maps, you would be forgiven if you would not be able to see that small speck of land, because Malta is 20 miles long, 5 miles wide. And that picture that you see there, that is it. That's all there is of Malta. And Malta has another 2 islands with it, Gozo and Comino. Population of 350,000. But the interesting thing, it is the only island in the Mediterranean which is a nation state. Most of the islands, other than Cyprus, which, as you very well know, geopolitically is divided into 2 separate entities, other countries are always part and parcel of a bigger mainland island. So it's quite an interesting place to be. And but once you land on this island, believe me, you don't feel as if you're going to fall off the sea. But because there's a lot to do and a lot to see, and there's a lot of people there. But I'm spending a bit of time around Malta, because I think where you live and where you grow up, it tends to influence very much what you do in later life. And for us Maltese, being in Malta was something to be proud of, was something to be so different from the rest of not just the islands, but the rest of the Mediterranean countries, because we managed to remain neutral politically, but also managed to create our own culture, our own language as well, our own alphabet, and our own history. And this is the Malta that perhaps you tend to see in brochures, you know, if you're interested in going in the Mediterranean for a sea cruise, etc. But it is what it is, in the sense that, you know, Malta is very, very much embedded in history. There's so much history, and predominantly because it's been colonized by every empire that you could think has touched the Mediterranean Sea, from the Phoenicians to the Greeks to the Romans to the French, Spanish, British, and others, and many others. So you get a potpourri of cultures, which is very much representative in our language, which is fundamentally Semitic Arabic, but we write it in Latinized alphabet. And that's me. I had an amazing childhood. I grew up in Malta, which was at that time considered as a developing country. I suppose I'm showing you these pictures to prove that I actually once upon a time had hair, but also that once upon a time I was young as well. And but what was important is that, you know, having this happy childhood, we were right in the middle of the Cold War. Grew up, you know, in a situation where you don't know what's going to happen. You know, where I remember very vividly as a child sitting and looking at the docks, and you see this American aircraft carrier leaving the harbor after it's been refitted, and the next aircraft carrier that comes in is the Russian one. And so it sort of created a sense of not anxiety, but and neither was it despondency, but a sense of vulnerability, but a vulnerability that is it encourages you to be resilient. And that's partly, in a sense, you know, two of the major occasions in Malta is actually surviving in spite of the situation. And the first one is the picture on your top right-hand corner. And these are the Knights of St. John Hospitaliers. And the Knights of St. John were the very old-fashioned Christian-based EU organization, which is essentially started when European princes and lords and kings taken over Jerusalem during the Crusades and set up the Knights Templars and the Knights Hospitaliers. And you can recognize the what they call the Maltese cross, which is essentially the St. John cross on the right upper corner, in most of the first aid ambulance brigades and other organizations around first aid, because that was initiated by the Knights. But that was at a moment in time in 1565 when Malta, in spite of, you know, the number and the vulnerability, has managed to beat the great Ottoman emperor at the time against all odds. And on the left-hand side is the flag of Malta, and you see another cross, the George Cross, which essentially during the Second World War, when all countries around the Mediterranean were occupied by the Axis, Malta was the only one which was not and never been occupied by the Germans or the Italians, even though they tried hard to do so. So there's a sense of pride, but again, resilience. So, of course, you know, very interested in medicine, applied to go to the University of Malta, which is the only university, and dutifully did my course in the medical school there. I think I was mediocre to average, and but there was something that, you know, for me wasn't right. I was going through a very old-fashioned British type of didactic lectures in the university, and so if you studied, I had a great pictorial memory, and so anatomy was fantastic, perfect, but actually it didn't really resonate with me at all around what I was actually trying to study, until I met my first mentor on the right-hand corner. And her name is Rita Shibaras, and Maria Shibaras, sorry, and who was a GP who was essentially, we met in one of these voluntary organizations who were helping vulnerable people, and she told me to come over and see if you can help, etc. And I was at fifth year medical school at the time, finishing and, you know, needing to decide what I need to do. And there, lo and behold, you know, I was talking to people who were street workers, talking to people who were homeless, people who were taking drugs at that time, you know, when officially in Malta there was no drug problem at all. And it got me thinking, and that invitation got me and Maria and other colleagues to set up what is now the National Addiction Service under SETA. And that was very interesting, because I remember when we opened the door, and the first day we had 100 people waiting for myself as a houseman working part-time, and Maria to initiate methadone. And then that's for me got me this sense of what is happening here. I never really in my medical school had a lecture around drugs. I think I remember I had 1 hour lecture around alcohol, and then later on in life I realized that that was not the exception. Actually, it was the norm of most medical schools globally. And yet, there were people there queuing in order to be supported. And I didn't know it at the time, but once I got really interested, I got a Commonwealth scholarship, and I did what was at that time the first postgraduate course in addiction. It was a diploma in addiction behavior. It wasn't even a master's degree, and that was at the Maudsley Hospital in London, where the Department of Addiction Behavior was a Portakabin, and the PhD students in that Portakabin was Professor Colin Drummond, Professor Michael Farrell, Ilana Crom, and others that you hear about and have done a tremendous amount of work in the field of addiction. But also I was encouraged to write my first paper. And it was the time when, so if you had a good idea, why not write it? And that was an ethos and the philosophy, which I said, okay, fine, let me write around something that I know about. And that was published in what is now called the Addiction Journal. Previous to that, it was called the British Journal of Addiction. I suppose I am slowly but surely hinting on how old I am and at what stage, we're talking here. Of course, it says first published August 1991. And as they say, the rest is history. With from there, I got really hooked around, trying to define myself professionally to be a specialist in the field of addiction. And that took me several routes, different routes. What I realized is that there was no specialty called addiction at that time, or addiction medicine, addiction psychiatry. So what I had needed to do is to do my psychiatry training, which is a 6-year training in the UK. So I went to the Royal Edinburgh Hospital and surrounding regions and did my basic psychiatry degree there. And then I had to spend another 3 years to do my advanced and higher psychiatric training in Cambridge University hospitals. And during that time, I had to do child psychiatry, forensic psychiatry, general psychiatry, old age psychiatry, and other faculties. But addiction seems to be always coming back into my forefront. And so I had an opportunity when I got a phone call from my second mentor, the late Professor Hamid Ghatz, originally from India, but established the first department in addiction behavior together with the people in the Portakabin in the Maudsley at St. George's Hospital Medical School. And I remember a phone call when I was in Cambridge asking me, would you like to take on a senior registrar at that time position in the lecture position, which I said yes. And this is very much either Maltese or being young or being naive, but I said yes, and I was traveling to St. George's every day for 4 hours from Cambridge to London and back, because my children were very young and I didn't want to disturb their initial years. So from there came a very difficult situation, a moment in time when children needed to go to a good school, needed to live in a very healthy environment, and we decided to go back to Scotland, and I accepted a position for a consultant position in Fife, which is near Dundee and Edinburgh, and in the senior lecturer position with Nine's Hospital Medical School, University of Dundee. And then 5 years ago, I was offered, well, I was successful for a chair in medicine, as I said in my introduction. So, interesting journey. And throughout these journeys, it was some, and these are, very important messages for the young investigators who might feel a bit bewildered and unable to really sort of, perhaps capture the moment in time, because they are so engrossed around what the future might hold. And part of the arrangement in working with the Royal Edinburgh Hospital is that you were able to do an MPhil at that time. It doesn't exist anymore, but it was an MPhil in psychiatry. And I decided yet again, to do something that few people have done for several reasons. And that was to look at, events and record episodes or identify a history of childhood sexual abuse in an adult population in Fife, Scotland. I almost did not get my MPhil because I was causing some problems within the Department of Psychiatry, because at that moment in time, and this is hard to believe actually, but we're talking of 30 years ago, that moment in time, the notion of post-traumatic stress disorder did not exist in the realms of psychiatry. So for me to be using the trauma symptom inventory on a psychiatric population and identifying PTSD type of symptoms was a bit revolutionary. I didn't intend to do that, but it was interesting that I remember when one of the senior lecturers asked me, be careful, because you might not be able to graduate. But that's history, and in spite of that, I've graduated and I got my MPhil and moved on. But interesting, when I moved on from Edinburgh to Cambridge, I was introduced to several people, and most of them are well known to you. And these are Professor Trevor Robbins, Professor Barbara Sahakian, his wife, and Professor Rogers. At that time, he was a senior lecturer with Trevor. And it was one of those situations where my psychiatric trainee took me to work for 6 months in substance misuse and the addiction services in Cambridge. And I was approached by Trevor, who honestly, I didn't know his reputation at that time. And we started talking around the role of neuroscience in substance users. My thought at that time was, yes, it is really important, and but of course that needs to be translational, needs to be pragmatic and ecologically valid. And I've participated, and more from a recruitment point of view rather than from a mechanistic intellectual point of view. But I've discovered that this is something that I wanted to do more about. And I suspect, Trevor always reminds me that the second paper on the right-hand side is one of the most quoted paper that Trevor and Rob Rogers have done, which shows the interest in this topic. And I moved to London thinking, okay, I want to do a PhD on this topic, but I didn't. And the reason is because the job in London was too busy. So even though I was promised the time, etc., so I had to shelve that idea. And in the meantime, what was happening is that being in one of these global centers of excellence at the time for substance misuse and addiction, and working with amazing people. I've just seen one of my colleagues just coming into this webinar, Christos, who was my colleague there. And what was happening is that throughout the 10 years or so, between actually 1997 and 2007, what was happening, I was becoming more and more involved around the field of comorbidity. At that time, it was called dual diagnosis. And it was more around, again, the magic words is being ecologically valid, being pragmatic and translational. And understanding that people who attended substance misuse services did not park their comorbid substance misuse and laterally their comorbid comorbid mental health and laterally comorbid physical health problems outside the clinic. That comes with the package, with the patients themselves. And it was pretty evident that the delivery of services that we were either being trained or asked to provide within addiction services was that to do around being opioid-centric, around prescribing methadone, but it wasn't around the patients at all. It was more an attempt to reduce, because the agenda was more around harm reduction, because if we provide them with methadone, the chances of people injecting would be less, and the chances of injecting and sharing needles would be less, and so there's the chances of bloodborne viruses infection would be less. So my career academically took me to understanding better what is happening in this population when it comes to experience comorbid mental health problems. And that's not only sort of took me to field of epidemiology, but also took me to the field of policy and consultancy with the Scottish government, UK government, and the European Union. And again, I'm putting in these papers here. They're available on ResearchGate or on the public domain. If not, just ask me, and I'll send you copies of them. And that went more and more into what now I can call, in reflection, can call is that my role, my legacy, my contribution to the field of research in the field of substance misuse is more around setting benchmarks and asking those questions, trying to find the answers using the right methodology. And so, for example, one issue on the top here, the comparison of accidental fatal overdose, published in 2011, was around, I am aware that, people who die of a fatal drug overdose are registered in one register, and people who commit suicide are registered in another. And I was trying to make a point here that if you link data and you identify these populations, what you realize is around 25% of the populations that have committed suicide are actually people who had a long and checkered history of substance misuse, and vice versa. So sometimes, information is there not based on the reality, again, the ecological validity of it all, but it's based around who the commissioner is and how the systems are organized, which tends to then disentangle what I would call reality. But again, going back, comorbidity allows you to understand better and to be more granular around the different types of heterogeneous populations that one sees clinically, but even outside the health and social care environments. So, and again, if you differentiate that same population and you look at populations that have been admitted to psychiatric hospitals due to diagnosis of drug and psychosis, if you do that process well, you learn that there are certain factors, precipitating factors, which might not necessarily be the same as the other populations that attend community services. And this goes on, and I was very busy with looking and presenting these. I was in the European circuit around comorbidity. We did further investigation around setting up treatment options for dual diagnosis users, Zoom instruments, looking at what were the factors which made people not relapse into substance misuse and or into mental health related problems, went into the realms of what actually does it mean being networking between services, and we've done a thesis around the nature, level and type of networking for individuals. But also what was quite interesting is that you find that a lot of the predictors or prognostic features around some of these populations are not necessarily because the cases are so complex and so chaotic. It's because the services are unable to cope with an organic caseload. And then, sort of these are other examples around the field of substance misuse comorbidity, dual diagnosis, looking at how, irrespective of what type of treatment, training you had, staff always had their favorite patients and not so favorite patients, and introduced the notion of stigma and what that means when it comes to delivering effective services for individuals. But also, people tend to stigmatize the people, but when it comes to the presentation, the psychopathology of the presentation, it might be no different from other types of psychopathology, which again confirms that unconscious or perhaps conscious discrimination in this patient population. So during that time, I mentioned around looking at dual disorders, predominantly comorbid mental health issues, but I was also involved in looking at comorbid mental, physical health issues, predominantly chronic pain. And me and my colleagues in anesthesia were the first of few who set up the pain and dependency clinics in the UK. I was in Dundee at that time and Fife, St Andrews, and what's quite interesting actually is that what was important here is that it's important really sort of what I realize is that there's so much commonality around when we medical profession tends to create these different types of diagnosis, different types of systems, but essentially it's going back again is that we can learn from each other's discipline and create a better service. So chronic pain was an interesting issue for us, and especially for me, but for the purpose of this presentation, it reignited my original conversations that I had with Trevor Robbins and the wish to do my PhD in the neuroscience of chronic opioid use. And these are for me, these are the seminal papers that in a way crystallized my decision really to do my PhD around neuroscience, hence the title, In Love with Puppy Love, Puppy Love. And that paper is written by Antonio Verdaggio Garcia, which I'm glad to say is a very good friend of mine right now, but when I was reading these papers in 2007, I imagined him to be a very old man indeed, which I was totally wrong. And especially the third paper, the Drug and Alcohol Dependence, Ecological Assessment of Executive Function, Substance Dependence Individual. And the other two papers on the right-hand side, written by Karen Ash et al. From Trevor Robbins and Barbara's department in Cambridge, which again looked at the granularity of things. The two elements from both these great people is that what was happening is that the profile of the cohorts that were being explored were essentially polydrug users or predominantly stimulant users, but not opioid users. And I realized in my sort of initial literature search that there aren't many there weren't many, well, right now there is, but at that time, 10, 13 years ago, there weren't many papers written where clearly, methodologically, people were exploring the executive function and the neurocognitive profile of opioid-dependent or chronic opioid users. On a sideline, as you know, this idea of me doing the PhD on this was around, and there was a seismic shift in the international platform around a notion that we need to treat substance use individuals who are using substances in a humane fashion, in a very sensitive fashion. And gone are the days, even though it still lingers on, the polarized views between harm reduction and abstinence, that if someone is on methadone and still taking heroin, that the person should be discharged, and because we cannot have one or the other, and things like that. And throughout the last 10 years, there's been a very interesting, I think for sad reasons really, shift in recognition by the United Nations, especially WHO, that one needs to effectively address in their own terms the world drug problem. And what is interesting for the next 10 years, and there are these identifiable sustainable development goals, which one of them is around good health and well-being, and target 3.5, which is the second row, the first on the second row, is around reducing and supporting individuals who use substances, including alcohol and nicotine. Okay, so this is the reality. So I was, intellectual, I was really interested in doing this, but also in a way I could justify this from a clinical perspective. And overall, overarching all this with the patients, grounding me into the reality of the situation. So this is from the World Drug Report 2018, where I highlighted here, opioids continue to cause the most harm, accounting for 76% of deaths, where drug use disorder was implicated. And that's not insignificant. But equally in the field of and these are pictures. There are lots of these pictures, but this is the sad situation that we've been in for the last 10 years, where drug deaths, especially opioid-related deaths, or a cocktail of opioids implicated, is going up. The left is the European figures, and you can see the dashed line, which is the Scottish figure, which is totally an outlier to the rest of the EU. And the right is that of the US, 2017, and you can imagine that the figures of 2018-19 would be higher than that. And so there was a clinical reality to understand better, if understanding the neurocognitive profile of opioid using individuals is important. And then this came around, and this is the table I use, in my academic department at St. Andrews. And this is to do around precision psychiatry. I call it precision addiction medicine. Doesn't matter what topic it is, but if you're able to link data from different sources, and that includes the neurocognitive sources, neurocognitive data on the right upper quarter, neuroimaging, but also as important, the clinical individual characteristics, the physiology, and also if you're in a system like in Scotland, where we have the community health index number, the CHI number, where every citizen has a CHI number, you can link lots and lots of primary and secondary care electronic data sets, primary and secondary collected data sets as well, which allows you to provide this rich tapestry of information, in your office, really, literally in your office. So of course, you need to collect the data first, and you need to collect good data. That would then provide this biosignature, and then you can actually then explore and investigate further population of interest. And that, for me, also crystallized what I've been doing in the last 30 years or so, but also justify the type of academic activity in the field of neuroscience. So the question was, is chronic opioid dependence associated with neurological impairment? Simple question. And of course, at the end of the day, the relevance was that as a clinician, I realized and said, all right, this is really interesting, because if there is cognitive impairment, why do we assume that our patients have intact cognitive ability to make the right decisions, but also when most of our psychosocial interventions are based on the assumption that there is an intact cognition? So I think that was what I just explained was a good enough reason to go into the field of neuroscience. But of course, when you ask a simple question, what you find out, what you never find out is a simple answer. And most of my first year of doing my PhD was around really trying to understand the narrative and the language used and the operational definitions of some of these neurocognitive domains. And glad to say that that was a very good exercise before I even started in determining what hypothesis and then subsequently recruiting. Because without this clarity, then it would be really very difficult to interpret, especially clinically, what you're finding. And so these are very familiar to most of you in memory and learning here. I'm not saying this is the ultimate definitions that everyone should be using, but it was for me a very helpful way of trying to understand better. So as a result of that, we looked in, and as the Medical Research Council and other councils would suggest, is the first thing you do is not only trying to operationally define what you're actually trying to understand better, but also do a systematic review. And if you're lucky enough to have a couple of really good articles, do a meta-analysis. And that's, learning the skills of doing that as well was very exciting and very, very fulfilling. And these are the papers that have resulted from my PhD and subsequent other projects. But predominantly, again, going back to what I said about my role, my legacy is around benchmarking, was able to, with the literature that is available, and believe you me, there aren't many literatures, there aren't many manuscripts with good science, good methodologies, and you always struggle when you find yourselves unable to do a meta-regression, because there isn't more than 10 papers to be able to do a meta-regression on some of the domains that I've just highlighted. And again, if you're interested in reading these, there's a ResearchGate, or get in touch with me. And the cohort trial was called NEMO, and people ask me, why did you call it NEMO? And essentially because my son was 6 years old, and he was, at the time, it was Disney's Pixar, Finding Nemo. And but of course, as you know, in Latin, Nemo is finding nothing. So I was well prepared for the eventuality that if you're doing a PhD, you're always hoping that there would be something earth-shattering, and that that you're going to find something that other people have not. But I was a bit of a realist as well, and essentially, I was ready for perhaps not finding much there, even though you do it methodologically in the strictest way that possible. So the hypothesis was chronic opioid dependence associated with neurological impairments reflected in altered performance, as I said, in impulsivity, cognitive flexibility, and memory. And do the deficits identified depend upon, and this is my clinical mind around the nature of the opioids, the context, and the status. if they are dependent or non-dependent, if they're injecting or non-injecting. And the third hypothesis is the degree of opioid exposure during acute intoxication, withdrawal, or when on methadone, which is usually used as the opioid equivalent once an individual attends treatment service to be assessed, titrated and tolerance tested, we call it, and change from illicit opioids to methadone, not to be parked on methadone, but with a view to anchor the individual's potential chaotic lifestyle to be able to work on his or her resilience and identifying their strengths and moving on to a better quality of life. Okay, and then we recruited, or I recruited a number of opioid-related groups, and the three obvious ones for me were the heroin group, the individuals who were still not in treatment but have been taking illicit heroin use, and the methadone group, which is the obvious one in a treatment service where people are usually on heroin stabilize on methadone. And then, of course, there were other people who were taking chronic opioids or opiates, and these were the people with chronic non-malignant pain. And then, of course, the healthy control. And the conclusion is that there were some significant neurological impairments reflected in altered performance, especially in cognitive impulsivity, motor impulsivity, and non-planning impulsivity. But chronic opioid-dependent users do not show significant impairment in cognitive flexibility. There was no significant neuropsychological impairment detected in the cohort with chronic pain, which, of course, sort of my notion was, is this a toxic consequence of the chronic opioids being used that has resulted in the impairment, or is this individuals who have pre-morbidly been made vulnerable for whatever reason? There isn't as yet longitudinal study going on for 10, 15 years from childhood. So, and the chronic pain cohorts was there in order for me to see if it is toxic or pre-morbid. And it's, of course, it made me think and say, well, what we're seeing here, people who are heroin and on methadone, are they pre-morbidly already vulnerable? And hence that's what we're seeing in the impairment profile. Injecting status, again, was a big surprise for me, because I thought, clinically, someone who's an injector is someone who's more dependent than someone who's smoking heroin, and so I would have thought that being an injecting status would have created a worse neuropsychological profile, again on the notion of if chronic opioids are toxic. Dependent status again contributed minimally to motor impulsivity, so it was quite insightful. And again, what has resulted is that most of my findings have been published, and you would see that what I try to do again from my previous experiences with dual diagnosis and clinically and academically is that you go deep into the granularity, even though you might think again that opioid-dependent individuals are a homogenized population, but actually they might not be, and especially in the field of neuroscience, when someone who's on heroin, illicit or otherwise, someone on methadone, and someone prescribed analgesic medication, and laterally, people who are on buprenorphine, people who've been abstinent from methadone and buprenorphine, we do not assume that they will have and present with the same neuropsychological profile. So these papers was an attempt to differentiate some of the, and again, benchmarking for people who are essentially looking at this from a mechanistic point of view, a molecular point of view, biological point of view, in order to appreciate that actually one of the worst things that you could do is to homogenize, not just stereotype, but to homogenize that the issues that you're seeing are actually present in all, because you have never really qualified the inclusion-exclusion criteria of your cohort. And so managed to get my PhD. And as you can see, it's volume 1. Actually, it had 2 volumes. And I remember, when I submitted this, actually, my chief examiner was Trevor Robbins. He said, yeah, your thesis is really, really important, but also important that it could be a very interesting door stopper. I wasn't sure what he meant by that. I think at that time I thought it was more related to the fact of the size of the volumes of the dissertation that I prepared. But we moved on, and again, working with really capable people, especially Serenella Tolomeo, who came over to Dundee and then laterally finished her PhD in substance misuse, and now she's a postdoc research fellow in Singapore and working in her own lab on this topic. We explored things further, and what we did is we did 3 things. One is that we continued to recruit individuals who were abstinent, so we increased the cohort domains of the original PhD, and also the fact that we got some money in order to explore structural changes that might be going on in the same population, and relate that with the neurocognitive domains that I've shared with you earlier on. And so from there, we set up a very interesting group that's been working very well with our colleagues in Dundee, with Professor Steele, and earlier with Professor Matthews, lateral with Professor Steele. And again, as I said, I'm not going to talk around the science of this, but it's interesting again, sort of conversations laterally again around the notion that perhaps, the third component that needs to be explored in this field is the emotional, the moods, especially depression, anxiety component. And in order to identify if there is actually a common mechanistic element related to this, but also really, sort of in reflection to the papers that were published by Nora Volkoff and George Coops around, differentiating the behavior and biological phenotypes in dependent individuals, especially in my case, opioid dependent individual in the abstinent population. And the third component is that we were aware that substance users, especially opioid dependent individuals, smoke tobacco, take cannabis, and also drink. And there's that notion of codependency. And again, as a benchmark, we needed to do some systematic review and meta-analysis around this. These topics. This is one of the very few functional analysis that we've done with my cohort. There's still loads and loads of data that hasn't been analyzed, and this does not come as a surprise to most of you. Is when opioids in this case hijack the reward systems, but also significantly reduce the loss value, encoding, and methadone maintained patient. But I'm mentioning that because that was my claim to fame. Not sure if people recognize the face, not just my face, but the other face of Brian Cox, who's a Hollywood actor, who came to Dundee to do some 4-part series for the BBC around Addicted to Pleasure. And one of them was around opioids, and was very much based around the research portfolio that I have just explained. But what's more exciting is around the fact that what happens is that you have your own universe and your own landscape, your own team, and you work on it. But what's also important, certainly for me, is the International Society of Addiction Medicine and the people that you meet as a result of setting up the Neuroscience interest group. And this is these webinars is a reflection of that group, but also the people within that group, and the discussions, the process within which you finish up, you know, setting up a roadmap, setting up a consensus statement when it comes to what do we need to do, how we need to look at the future rather than rehashing the same thing over and over again. And as you can see from the authors here, you know, they've done excellent work in their own right, and we decided that there should be you know, a roadmap really to look at what needs to be done. And this is one of many. And again, you know, it's my team with Saranella and Douglas, but also with Hamet in this case. And looking at, you know, what's important here is that the benchmark is there, it's all done. But what we need to do now is, and I think we did the evidence around susceptibility risk markers, diagnostic markers, predictive prognostic markers is there, is how do we then make sure that these neuroscience-based interventions are, again, using the word ecologically validated to be used in the clinical environment as either assessment tools or as intervention tools. So yeah, I've put in here, I mentioned a couple of mentors. Hamid Goss is at the top, and then we have Bruce Ritson from Edinburgh at the bottom. And again, mentors, not supervisors, mentors are so helpful, so helpful. Good and bad times. Just put the maps here where I spend most of my time in the UK. But the last two slides I think are the most important slides here. I don't know how I'm doing with time. Okay, so and I think, you know, this is important. So my mantra is not, I think it's easy to be successful. It's easy if you have the right time, the right resources to reach the peak. If you have the right motivation, the right ambition, etc., etc. The issue is, how do you sustain being excellent for the next 30 years? And that's a challenge. That's a big challenge. And you see a lot of people who, you know, become professors and do lots of things, and then suddenly you don't see any papers from them because they either left, they've burned out, they moved on, they're disillusioned with the system. So these are some helpful guides for people to sustain something that they enjoy doing. First, most important is be kind to yourself and others. Please be kind to yourself. Relationship capital, invest in relationship. It's not about the outcome, it's about the process. It's about the people you meet. It's about the relationship that you have, you know, professionally, but also personally. Do not make your professional ambitions the one and only thing in your life. Failure is an opportunity for success. And this is an example of, you know, if you get your papers rejected in an impact factor 5, do not resubmit this in an impact factor 2 or 3 because the reviewer said so and so, exactly. No, actually resubmit it in an impact factor 8. I talk from experience. And you get that accepted. Believe in what you're doing. If you don't like the topic, move on. If you don't believe passionately what you're doing, think seriously, because you will not be able to sustain that for 40 years. Do not try too hard to be like someone else, yeah? Be yourself again. Be kind to yourself, but be yourself. Journeys take you to interesting places, and they are never straightforward. And I remember, you know, we have our own big plans, and sometimes they don't work for whatever reasons, usually good reasons. They don't work, but it does not necessarily mean that's the end of the road. You can always go back, find the right time, right opportunity with the right people. Do not plan your future on one topic. Do what you enjoy most, as I said. And last is, it's okay to feel, to experience the imposter syndrome. Yeah, and it's fine, irrespective of when and what age, you know, what seniority you are, you always get that sense of feeling. And that's more about emotional intelligence, about being aware and acutely aware and insightful that actually you're not as perfect as perhaps some people think you are. Patience is a virtue. Learn the art of humility. I always, please, you know, no matter how important you are, being humble is the most important thing that people remember of you. And you are worth it. Last but not least, just to remind you that next year we have the International Society of Addiction Medicine in Malta, which I'm very proud to say is happening in the old city of Valletta between September 27th, October 1st. So I hope through Neuroscience Interest Group, you'll be able to participate and contribute. Thank you very much.
Thank you very much, Alex. Thank you very much for this, for sharing your personal experience or your clinical perspective on these important issues. And also this point of view from someone who has been working for 30 years in the field. And I would like to open the discussion, if I may. I don't know, Hamed, is it fine if I begin with the discussion?
Absolutely.
By asking you, well, first by congratulating you for your work, and also by mentioning that many years ago, probably 25 years ago, I remember when some colleagues of mine were trying to do a paper related to some health complications among patients with psychosis. And they wanted to compare the group, the non-smoker group with the smoker group. And of course, they were not able to complete the non-smoker group because everybody was smoking. So I would like to emphasize the big change that has happened along the last 30 years in terms of our understanding of comorbidity. And in that sense, I would like to ask you, what's your experience in terms not only about understanding the great comorbidity between substance use disorders and mental disorders, but in terms of treatment? Do you think that we are really addressing this important issue the way we should?
Yeah, excellent question. The honest answer is, I do not think so. We have all the evidence, and it is not a matter of not understanding the characterization of the population. It is more a matter of the decision-making process within the policy and platform that actually systems, and this is where I would encourage people to explore and investigate further systems, how systems can be a barrier to what I would call common sense and based on evidence. So there, we talk around care pathways, and we talk about liaison. We talk about different types of patients needing different types of treatment packages. But yet the systems are still dependent on who funds them. And there are attempts, political or otherwise attempts. So within Scotland, for example, in the last 10 years, the healthcare system has integrated fully with the social care system, but that was very much based around supporting older, frail populations. But within mental health and substance misuse, we are now, because the system is now established and embedded, we're now looking carefully on how we can sustain a system that is fluid enough to move from one situation, one service to another without creating unnecessary barriers. So it has improved in some areas. So for example, when it comes to appointments time and the time from referral to assessment and creating a biopsychosocial package, irrespective of what the needs are, so not necessarily needs around dependency, that has improved, and services are marked around the performance around that. But that is not a global thing. That's based around specific countries around the world. Well, I worked with the WHO for about 5 months last year, and my remit was to support the the mental health and drug policy unit in Cairo, and so we were responsible to support governments, from Morocco to Afghanistan, Pakistan. 10% of the world population, half of them are in chronic wars or warfare. A lot of humanitarian, a lot of individuals, don't have a house, don't have anything. And what is said because of the broken system around is that there is no medication available. So even though you might have the framework, the system within which the basic components of that system might not even be there. So yeah, I like that question, but I don't know if I actually answered your question on that. But thank you for asking.
Thank you for this inspiring talk, and also for allowing us to think about the implications of what you said, because many times we know we have evidence, but we are not able to put that into practice. And I would like to ask Hamed if you would like to read some of the questions. Maybe we could do, whatever you want.
What can we do right now is just asking people to turn on their video. And Alex, if you stop sharing your screen, then we can have a kind of larger space for everyone to we have a limitation. Yeah, we have a limitation in terms of the number of videos. You can have just up to 25 videos on the screen. But those, especially those who have questions, they can just turn on their videos and just ask their questions. And Sylvia would manage the discussions and the timing. We still have something like 20 minutes left for the discussions and the things that we can do. And sometimes I just found this last part of the meeting is really fruitful part of the meeting, because people would be able to interact and discuss about their challenges and things that are happening in other parts of the world.
I apologize if I don't pronounce the names properly. So probably I would say Irene, but it's probably Irene. Says hi. Can you? I can't see you. Can you please?
Well, I think do you have my video now? Yeah, camera should be on.
Yes. Could you ask your question, please?
Well, yeah.
From Denmark. Yeah.
Yeah, that's right. Well, actually, someone else also asked the relevant question about methadone and buprenorphine cognitively, because when I started in the field in the year 2000, someone asked me to compare methadone and buprenorphine cognitively, even to compare it when people were on methadone and then when they had switched to buprenorphine. So I set up that to do it as an outpatient research, and got a grant, but had to stop it because people use so much cannabis and benzodiazepines and everything else that I thought this would lead to absolutely nothing, because they're outpatients. So has anyone actually done it? Because you need to compare the patient to themselves, someone who's on methadone and then switch to buprenorphine, and do they function better cognitively? So has anyone actually done that? Because I failed to.
Yes, Irene. What I did is actually, have two separate cohorts of buprenorphine, who are not taking cannabis or benzodiazepine, and another cohort of methadone. But following up individuals who were on methadone and then transferred to an appropriate dose of buprenorphine, I do not think anyone has done that yet. What I did in my studies is I followed up people who were on heroin and went into methadone, and that is the next type of studies that needs to happen. The methodological issue around that is that you do not know, when you're recruiting the people on methadone, who are going to be transferred to buprenorphine, because of course we're looking at chronic consequences and impairments of chronic use. But the meta-analysis, the systematic reviews that I've done, looking specifically at the buprenorphine, specifically at the methadone, who were first-time users or they've never really been used other opioids, indicate that buprenorphine seems to have less neuropsychological impairment. But there's always an insurance policy clause The numbers are low, the power is low, the quality of the papers published is of medium quality.
Yeah, because the problem is that people sometimes self-select for buprenorphine if they actually are better functioning. So that's the issue there. So
exactly.
Yeah.
There's so much bias going on here. There, yes, selection bias as well, self-selection.
Yeah, self-selection, precisely, yes.
And also you have this comment about that you almost have no COVID-19 among addicts in your country. Can you say something about it, please?
Well, we're wondering about it because also the hostels for the homeless and everywhere else in Denmark, we have been asking each other, do you have COVID-19? And there's been almost none. And we are wondering whether our population is so segregated from everyone else, because they seem to. And of course, they actually have been taught very much about hygiene, and they use face masks a lot, and they really look after themselves. But even so, they should have had some infection. But, you know, of mine, one probably had COVID-19 when he was in Sweden, and he is Swedish, and that's about it of many hundred patients that I know. And in other parts of country, they maybe have had one or two who've had COVID-19. And we have tested a lot. We have outdriving testing as well. And our nurses can test for COVID as well in our clinic and send the test off. But we have found sort of none, and we have done numerous tests. So is that the case in other places, that these patients are so segregated that they don't get COVID-19? That's an interesting question.
Yeah, yes, and Irene, you know, this was the same conversation we had last week when we had the ISEM Victoria, the virtual conference, that actually it is quite surprising. No one really knows what's happening. But if I talk around Scotland, every board, and there's 15 boards, we had literally a couple of people who tested positive, and no mortalities as a result of COVID-19. So I don't know if the US figures are the exception or the rule, but when I shared that with my Canadian counterparts and other, you know, within the international platform, they agreed. They had the same observations and conclusions as yourself.
Okay, so we don't know actually what's going on. Why? No. Okay.
Yeah, Barbara would like to comment on this point, please.
I heard an interesting theory that so many of the folk who I work with who use drugs smoke very heavily, often untipped cigarettes and often very poor quality tobacco. So they inhale and build up huge amounts of tar in their lungs. Somebody suggested to me, almost facetiously, that it might be that the tar deters the coronavirus from getting into the lungs. That would make an interesting research.
Okay.
Yeah, I've heard that before, Barbara. I did, and it is quite interesting. You know, I think it's a combination of things. You know, the homeless were accommodated in hotels. You know, the health infection control methodologies, which were already there, as Irene had mentioned, about hand washing, about sterility when injecting, etc., were already there pre-COVID. But I also have this hypothesis, and it's unfounded, is that, you know, different phases, acute phases of the COVID-19 is affecting different types of population. So the fact that substance users, and here we include also people with alcohol use disorder, have not perhaps been affected so much, it does not necessarily mean that they will not be affected in the future when we have our next acute phase.
Hamed wants to talk, but first let me apologize because I was fascinated with this discussion and I forgot to ask you to introduce yourself before asking your question. If you might, please. Barbara, would you like to say, I've read that you're from Dundee, but probably you would like to introduce yourself?
I'm a parish nurse working with homeless people in Dundee, many of whom have addiction issues, not just with drugs, but with alcohol, porn, all sorts of life-limiting problems.
Excuse me. Irene, would you like to say?
Okay, well, I actually graduated as a doctor in 1991, and I'm a specialist in general medicine. But instead of buying my own GP practice, I started working with addicts in February 2000 and have done it ever since. So we both have multi-drug addicts and also pure alcohol addicts and everything. And as I wrote, also out driving teams. So we got 8 workers, nurses, social workers and such like, who drive around all Copenhagen and some part of the island where Copenhagen is, and treat them at their home, at their hostel, or out in the street. So it's very interesting and sometimes very busy. And today I did a hospital visit to get one into treatment, and well, the most difficult part was finding a parking spot at the hospital, but eventually after half an hour we parked at the hospital and spoke with the patient and the nurse and the doctor, and he started buprenorphine or Suboxone film today. So just interesting clinical work, and that's what I do.
Thank you very much. James, please.
Yeah, just following the discussions that we had in terms of the prevalence of COVID-19 cases among substance users, it's quite amazing that in Iran there was a sort of, there is still a current discussion in terms of the surprise of having really low number of COVID-19 cases among substance users. So when you see that it's being replicated in many different cases, I mean, in many different contexts that we have around the world, that basically makes a kind of quite an interesting scientific inquiry that, I mean, why this is happening around the world. And even there are some videos in terms of drug users discussing among themselves that none of us has had experience having COVID-19 cases. And if you live in Iran, and if you practice in Iran, I mean, you definitely have heard about that, and people are quite kind of surprised at why this is happening. And even in terms of the experience, there are ideas that, okay, it might be related to the opioids and the pathways related to opioids, or some other potential reasons. But it would be interesting discussion to follow in the future.
Sure, only to put the information together would be very valuable, because I've heard exactly the same thing in Mexico. Why aren't they getting a bad time? I mean, in terms of COVID, they are surviving well. Many of drug users are surviving well. Well, we have several questions here, several also congratulations for Dr. Baldacchino, but I would like to ask Dr. Smith from Forth Valley if he could ask his questions, please, and to introduce yourself.
Sorry, what was the question?
If you could ask your question. If you would like to ask a question.
I've been contributing. I wondered about benzodiazepines in your study population on cognitive function, but you found benzodiazepine-free individuals.
Yeah. Yes, yeah. You know, the thing is, you know, when you're doing neuroscience type of work, you know, you need to find a balance between trying to, you know, make it as neurologically, you know, relevant as clinical. So, for example, they were all males, they were all right-handed individuals. So there were lots of components that you had to either exclude, include, and match with the other cohorts, including on the drug use and alcohol dependence.
Yeah, thanks. I mean, in terms of COVID, certainly in Scotland, being around alcohol is seen as a major risk factor, because they've closed their pubs, stopped us drinking in restaurants, and which is interesting because it hasn't necessarily come out as an individual risk factor for COVID in the recent study in the BMJ, although tobacco smoking did, and cocaine and amphetamine and heroin use did. So, but that was based on GP records. So it's kind of odd question. Does drinking heavily predispose you? I don't know. I would have thought yes, but we don't have the evidence. Yeah.
Thank you. We have some other questions or comments from Roshan Bat. Would you like to share them with
yes.
the audience?
Thank you. First of all, thank you for this talk. It was very inspiring and very motivating for early career addiction medicine professionals like me. And thank you, NIH Neuroscience Interest Group, for the same. Regarding COVID-19 and discussion on among the opioid use disorder or addiction patient, in my clinical experience, I am from India. I practice in Delhi, and we run one of the largest methadone maintenance treatment program. So out of 1,000 patients who are in regular follow-up in our clinic, only 4 are tested positive. And in Delhi, the rate of seropositivity is around 40% in normal population. So that is very surprising to see that why there is a low infection rate among our patients. So we are also surprised with this kind of things. So it is worth studying actually further. If it is a global experience, then there must be something which we need to find out.
Well, thank you. Owen, would you like to ask your question, please?
Sure. Alex, thanks for your presentation. We've had a number of discussions about transcranial stimulation. And I just wondered, in your opinion, you know, I guess subject to more research, do you see this form of treatment, you know, monotherapy, being more widely accepted, not just in the UK, but in other parts of the world?
Yeah, you know, in a way, Owen, you know, what you're asking is exactly what my last 2 slides around the papers that I was part of with Hamed, is that neuromodulation and similar type of interventions are the way, you know, to help in improving the therapeutic options for individuals with. But we need more studies to understand better how this, you know, and how this type of intervention, amongst other types of interventions, which hopefully would be neuroscience based, actually what type of benefit, what are the outcomes that would happen, you know, if these are done before they are then introduced into the clinical environment. You know, Owen, you know, the NET that you do is nothing new. It's been there for 30 years, 40 years. The notion of, you know, stimulating the endorphins and you know, within us is something that's being intuitively seen as an important component in the future research. But as I said, you know, sometimes you need to wait 30 years before you have the right people and the right instruments to be able to do these things. So message is, Owen, never give up.
Yeah, I won't give up, don't worry. Thank you.
Well, thank you very much. I think we all should have this home message about the importance of understanding addiction not only as an isolated disease, but something that has to do with so many variables, and we need to teach everybody else and to be aware of the importance of treating patients as whole human beings with comorbidities. And thank you very much for your time, for your questions. You have many congratulations from people around the world. And thank you very much for this opportunity to host this session.
Thank you.